Hereby, I open this academic ceremony in which Robert Dzhanaev will defend the academic thesis, FETUIN-A-BASED THERANOSTICS in ECTOPIC calcification. May I invite you to present a summary of your study and the conclusions of your thesis.
Thank you, dear Prorector.
A bit higher up the microphone.
I think works now. Yeah, okay. Yeah. Dear professors, dear colleagues, dear family and friends, thank you for attending my defense, both in person and online. As my research has focused on mineral disturbances, I would like to start with a short introduction on biomineralization. By definition, biomineralization is a process of incorporating mineral from the external environment into body tissues. It is a valuable feature that, among many other things, allows movement on land and protects vulnerable organs. But if you think about it, growing rocks inside or around the body isn't the most intuitive solution to enhance adaptation. There was a period of time about 550 million years ago when the diversity of complex life increased dramatically. Now we call that period the Cambrian radiation or explosion of life. During that time, the atmospheric oxygen levels as well as seawater calcium content spiked up, and now we believe that those were the main driving forces of the Cambrian explosion. Under such conditions, our distant ancestors, pretty primitive creatures back then, learned to strengthen their bodies with inorganic matter. Since then, many life forms have mastered the production of various biominerals, including calcium carbonate and silica, mainly adopted by aquatic creatures, and hydroxyapatite, which constitutes the mineral basis of vertebrate bones. Now, how do we actually internalize calcium? A form of vitamin D, called cholecalciferol, is synthesized in the skin when it's exposed to ultraviolet light. This compound then undergoes a series of enzymatic transformations, first in liver and later in kidneys, to become a functionally active form of vitamin D3, which can in turn enhance calcium absorption in the intestine. Now, the classical theory regarding the further calcium metabolism says that calcium in its ionic forms then enters the bloodstream and is transported to target organs. However, there are some studies showing that the bone biomineralization rate do not match the calcium ion content in the bloodstream. And we think we know how the missing calcium is being transported. So on this slide, you see the 3D structure of FETUIN-A, a liver-derived plasma protein that has certain features, characteristics, such as charge distribution and surface shape, or post-translational modifications, that allow it to bind calcium phosphate clusters. Calcium phosphate inevitably begins to form when calcium enters a phosphate-rich liquid such as blood or serum. To prevent precipitation of nascent mineral, FETUIN-A binds calcium phosphate and forms calciprotein particles, or CPPs, thus allowing calcium to reach the target organs. In pathological conditions, the natural systems and mechanisms that mobilize the mineral can fail, and then we witness ectopic calcification, or deposition of insoluble calcium salts in soft body tissues. Ectopic calcification can significantly worsen the course and outcome of the underlying condition, and the vasculature is known to be most prone to calcification, as it forms a primary interface between plasma supersaturated with calcium and phosphate and the rest of the body. Some other examples of ectopic calcification include calcification of kidney, joints, lungs, and skin. So, to develop novel ways of managing ectopic calcification, I chose a theranostic approach, which includes both diagnostics and therapy of this pathology using engineered proteins. This figure schematically depicts an atherosclerotic plaque. Advanced plaques, as we know, can develop microcalcifications that render them vulnerable and prone to rupture. My idea was to produce a probe that would target microcalcifications representing the earliest stages of the pathological process. So, as I mentioned earlier, FETUIN-A preferentially binds to the nascent mineral. So I decided to exploit this feature to produce a fusion fluorescent protein by coupling the molecule of FETUIN-A to a green or red fluorescent protein with the help of molecular engineering. The FETUIN-A domain would then bind the microcalcifications, and the fluorescent protein would make the entire probe visible. To preserve the naturally occurring post-translational modifications, I decided to express the proteins in a mammalian cell line. Next, FETUIN-A can be also labeled with a radioactive tag instead of a fluorescent protein to enable nuclear imaging of microcalcifications, and that's what I have done. So I radiolabel FETUIN-A with metastable isotope of technetium, but in theory, any other radiolabel or radiotag with different half-life and suitable for a different visualization technique can be employed here. So, and this is what microcalcifications of heart look like. On the left, you can see a micrograph of myocardium captured with contrast-enhanced microscopy. The tissue looks normal with only one feature detectable. Then the sample was stained with a red FETUIN-A, and we performed fluorescence microscopy. It revealed multiple microcalcifications surrounding the larger lesion, as shown in the image on the right. To evaluate the sensitivity of the novel probe, I stained calcified kidney sections with both fusion fluorescent protein and alizarin red, which is a histological stain commonly used to detect calcifications. At first glance, both methods appear to detect the mineral equally well. We increase the magnification and again see that both stains allow us to identify the very same calcified lesions. But if we zoom even further and increase the resolution, we would notice that the green FETUIN-A fusion protein precisely detected the fine features of intratubular calcification, whereas the standard probe, alizarin red, did not detect any evidence of pathology. So, and this is important because nowadays electron microscopy, which is a very costly method, is still routinely used to diagnose renal pathology, partly because the currently available histological probes are not sensitive enough to detect subtle or initial changes in tissues corresponding to the early stages of the disease. So given this, the development of novel diagnostic tools seem to be a promising field. Imaging agents based on naturally occurring proteins have further advantages. For instance, they're non-toxic, so that they can be used in living cells to monitor the processes of calcification and mineralization in real time. On this slide on the left, we see human mesenchymal stem cells that were differentiated toward osteoblasts or bone-producing cells, and on the right side, some undifferentiated cells can be seen. Both cultures were stained with a fusion fluorescent protein, with the green one, so that the green color here indicates areas of membrane-associated mineralization. As osteoblasts are physiologically mineralizing cells, they are not affected by calcium phosphate excess in their immediate environment as most other cell types. And here's an example. On the left are vascular smooth muscle cells that were cultured in calcification medium, and here the fluorescent FETUIN-A reveals irregular patterns of cell debris calcification. Such procalcifying conditions are often observed in CKD patients who have elevated serum phosphate levels, and models like that demonstrate that calcium imbalances are indeed very toxic to cells. And again, we do not observe unspecific staining if the cells are cultured in medium with normal calcium content, and as shown in the image on the right. And at this point, we can conclude that the application of novel fluorescent probes grants us a deeper insight into physiology and pathology of mineralization. Now, without the therapeutic part, the developed approach would not qualify as theranostics. Established microcalcifications are extremely difficult to treat, and simply because the mineral is insoluble at physiologic pH. In fact, there are currently no medications that are capable of reversing calcification process, and severe cases require surgical intervention. But in fact, surgery is not always possible, especially if we are dealing with a generalized process of ectopic calcification. However, there is already a mechanism in the body which has to do with biomineral dissolution, and namely bone resorption by osteoclasts. During this process, highly specialized cells derived from white blood cells degrade the organic matrix and inorganic component of a bone. The problem is that physiologically, osteoclast generation is restricted to bones and teeth. But perhaps there is a way to trick nature and trigger osteoclast production in an unusual place. For example, during the development of an atherosclerotic plaque, there is a constant influx of white blood cells to the interior of a plaque. These cells will try to dissolve the plaque debris, fail at some point, and eventually will turn into foam cells. But what if we administered a drug that would reach the microcalcifications within the plaque and simultaneously stimulate the white blood cells, which are already present there, to stimulate them towards osteoclastic lineage? Once mature osteoclasts appear in the plaque, they start to resolve microcalcifications, thus reducing the risk of plaque instability. So, to generate an agent capable of targeted osteoclast activation, I again turned to molecular engineering. As with fluorescent fusion proteins, I took FETUIN-A molecule as my starting point for its ability to bind microcalcifications. So, to its C-terminus, I coupled a cytokine called RANKAL, which is physiologically produced in bones and is responsible for osteoclast activation. So the resulting fusion protein was intended to be tested in an experiment where bone or similar material would be pre-coated with a fusion construct, and then white blood cells are seeded onto this material. The final idea was to measure the area of resorption upon osteoclast activation. This is an electron micrograph of an osteoclast residing on bone. It was generating from precursor cells that were stimulated with a fusion protein. It has all the features of a mature cell. It is firmly attached to the substrate, it is large in size, but most importantly, it is actively resorbing bone, as demonstrated by the white vesicles on its surface. Those are transport vesicles containing calcium and phosphate from underneath the cell. During bone resorption, the following occurs. Activated osteoclast attaches to the bone surface and seals the space between itself and the bone. It then pumps acid into this sealed microenvironment, and the acid solubilizes the mineral. The osteoclast absorbs resulting microscopic particles containing calcium and phosphate and releases them into the external environment on the opposite side of its membrane. And that is what we observe here. On this slide are some further images of osteoclasts produced upon stimulation with RANKAL ligand, as in the image on the upper left, or with the fusion proteins, as in the rest of the images. In all cases, we can observe giant multinucleated cells, and the image on the bottom left, which is a scanning electron microscopy produced image with false colors, shows us that those cells were capable of resorbing bone. Just to explain on it, during osteoclastic bone resorption, the cell is making resorption pits and trenches, and those features are clearly seen on the slide, and the cell itself is depicted in green. Finally, to assess osteoclastic resorption, I seeded osteoclast precursor cells in calcium phosphate-coated plate, which was pre-incubated with the standard cytokine or the FETUIN-A-based fusion protein, and measured the area of resorption a few weeks later. Here we see that pre-incubation of the plate with RANKAL alone or with the vehicle is not sufficient to cause osteoclast activation. But if we pre-incubate the plate with the fusion protein based on FETUIN-A, we see that there is an exuberant cellular response. And if we, instead of initial pre-incubation, continuously add fusion protein within the medium exchanges, we see that there is a dose-dependent osteoclast activation observed in this plate. And yes, I think these results suggest that the targeted cell therapy may become a possible therapeutic option for ectopic calcification, and in general, I hope that the findings of this dissertation could convince you that the FETUIN-A-based fusion proteins are a promising theranostic approach to mineralization disorders. With this, I'd like to thank you for your attention. I give the word back to the rector. Thank you.
Thank you very much. It was a very clear presentation that I could easily follow as a non-specialist. That was the intention of this presentation. If you like, you can relax a little bit, take some water. Is there water for you around?
Yeah, that's
yeah?
okay. I'm fine.
And you can find a chair if you want. And we open now the opposition. And the first person who will start asking questions is Professor Tim Welting. He's professor in molecular cartilage biology here in the Maastricht University. May I invite you to start the discussion?
You may, Paul Rector, thank you. So, dear candidate, my congratulations, obviously, with a beautiful thesis and a Van Gogh-style cover, which is quite inspiring. And I was wondering, so when you were first starting actually with your presentation, it says vascular calcification on the front, while the cover says ectopic calcification. So let me start with trying to be clear on are we here for the vascular field, or are we here in the general, more ectopic calcification field?
My highly esteemed opponent, thank you for your words and thank you for your question. Yes, indeed, the covers are slightly different. As I mentioned during my presentation, vasculature is always in direct contact with calcium-rich liquid. So the majority of cases of ectopic calcifications are indeed observed in vasculature. So that I decided to name the presentation like that. But yes, the thesis is about ectopic calcification in general, because I showed the application of the probes.
Okay, then I'm really happy, because I have no clue about vesicles, about the vascular field. I'm more into the ectopic calcification field, so I'm happy that I'm not in the wrong committee, actually. Thank you. So the other question was the theranostics. So could you briefly reiterate your idea of the definition of theranostics, because I'm quite green in that still.
Yeah. Thank you for your question. So the theranostic approach relies on the use of a molecule which can at the same time be used for treatment and for diagnostics.
Right.
In this case, the molecule was FETUIN-A, which has certain characteristics which allows it to bind to nascent mineral, so the early forms of calcifications. And depending on the attachment, what we attach to this protein, we can either detect calcifications, as in case with fluorescent proteins, or we can try to develop a tool to resolve calcifications, like by using targeted osteoclast activations, as I showed in my latter slides.
Okay, so it's the combination.
Yes.
Yeah. So that brings me then actually to what was supposed to be my first question, but we already had to. Because your aim of the work that you show, amongst others, starting at page 85, I think, when you are developing the fluorescently labeled FETUIN variants, the whole idea behind these variants, so then I'm talking about the phosphomimics, ruby and emerald variants, your idea was to actually create a more sensitive probe. So on one hand side, I don't really see how we can use those probes actually to treat calcification rather than see them or quantify them. But I was looking at an answer to why do you need a more sensitive probe? Was the original one not good enough? And then there's only one figure actually in that chapter that describes like a quantitative comparison between the probes, and I'm not really seeing that difference in the fluorescent images that you're showing. So,
yeah.
So these are a lot of questions. Sorry. So why did you need a more sensitive probe?
Yeah. Thank you again for your question. So maybe I can go back to the slide which you're referring to, and there are quite some animations there. But yeah, so I'm talking about this slide, for example. Here we see kidney section. I don't know, it's just not working. Yeah, I think here it is. So I'm talking about some fine features that cannot be detected using standard probes. In this case, it's alizarin red.
Yes, but sorry, I'm going to interrupt you because I'm not referring to the alizarin red. Because in that chapter, actually, you described that you already had a Alexa Fluoro 488 labeled FETUIN.
Yeah.
That seems to be not good enough to you. Why is that?
Now I got your point, thank you.
Yeah.
So there are indeed several reasons for that. First one is that chemical labeling with FETUIN-A is always, like in every chemical process, you have to estimate the amount of the protein, you have to estimate the amount of the stain you are adding to that protein, and depending on your handling technique, it's always a ratio. You cannot really quantify this accurately because, like, if I perform the staining, if I perform the chemical labeling of FETUIN-A, it might be 5 molecules of fluor or 4 per molecule of FETUIN-A. And if someone else does that, that can be 2 molecules of fluor.
So you didn't want the more sensitive probe, you wanted to have a more reliable way of producing it.
That's one point. It's more reliable. And the second point is that you cannot make the cells expressing Alexa fluor-labeled proteins because it's a completely artificial process. Whereas I show in my thesis that this probe can be encoded in a plasmid, and the cells can be transfected with this plasmid and start reporting calcifications in live and in vivo. And this was an interesting finding of this work that cannot be reproduced with chemically labeled dyes. Yes.
Yeah, okay. One detailed question about that is actually, let me see, I think it's on page 91, where you compare the emerald version with the ruby version. And I think then what you see, so you did a precipitation assay in figure 2 on page 91. And there you see actually that the normal FETUIN version, so not the phosphomimic version, is inactive. Yet, at the other page, so do you see the figure? So it's figure 2E.
Yes, yes.
So it's inactive. Would you agree?
You're referring to FETUIN-A emerald.
Yeah.
Yes.
Okay. Then we continue to the next page, figure 3, and then you use that probe in the, I think in the panel E actually, to stain those cells. So how does that work? So on one hand side, you show actually that it is inactive in avoiding calcium phosphate precipitation, yet you're able to stain calcium phosphate particles with this particular label.
Thank you for your question. I think you're referring to the image on the second page, like afterwards.
Figure 3E.
3E, right? Yeah. And if you look there, it's not FETUIN-A emerald, it's PM and FETUIN-A emerald. So that's the modified version that has the modified residues and fully restored functionality of FETUIN-A part. So this is indeed not the protein, the initially used protein.
Then it was too early this morning, I'm sorry.
Thank you for your question.
Okay. Okay. Then I'm looking at the prorector. Is there time?
One short question.
Okay, thank you. Maybe then you can contemplate on the therapeutic part. So in the case that you are indeed able in a patient, like in a real life patient, if you are able to actually detect those microcalcifications, how would you foresee that, implementing that into standard patient care? So will you even or ever be able actually to find those patients? Because normally, probably, this is going on like subclinically. So normally these patients would probably never visit their general practitioner or an outpatient clinic. So, I mean, fantastic technology, and then how to use it.
Thank you very much for your question. Yes, indeed, those microcalcifications are nearly invisible using conventional techniques. And that was one of the reasons why we are interested in developing new diagnostic tests. Because studies show that those microcalcifications, they are basically the ones which are destabilizing the plaques, causing vulnerable plaque formation, and vulnerable plaques are prone to rupture.
But that patient will never go to the clinic.
It's often a co-founder, like if we have a patient with calcification in, like if we have coronography and we detect calcifications, we can suspect that the patient also has calcified plaques.
Okay.
And those microcalcifications are really the ones which can cause problems.
Thank you. I need to give the word back to the prorector. Thank you.
Thank you very much, Professor Welting, for your contribution to this defense. I give the word now to Professor Manuel Meyer. He's professor in cardiovascular proteomics at the Imperial College in London.
Thank you. Dear candidate, it's a pleasure reading your thesis. I have a question regarding figure 9 in your thesis. where you were evaluating different proteins for their calcium binding properties, and only chemically labeled FETUIN and osteopontin were found to be effective. So you basically went ahead with those two proteins, but you ruled out milk fat global membrane protein and albumin. And I wanted to get a bit more insight about, what is it, for example, about milk fat global membrane protein that doesn't bind as efficiently as osteopontin or FETUIN. Are there other calcium binding proteins you could think of that could be used for the intended purposes?
Thank you very much for your question. My highly esteemed opponent, indeed, I tested several proteins for their calcium binding properties and for their potential application as imaging and therapeutic agents. And indeed, we tested, I'll start with the beginning with the milk fat globule membranes. The first thing about it is that it's actually a mixture of proteins. It's a mixture of proteins on a fat membrane. And it's not a very reliable source of a protein to stain and of a protein to develop a diagnostic probe of. But there are indeed many proteins. For example, casein is a milk protein which is believed to be one of the most powerful calcium chaperones. But I didn't look at this particular protein because we believe that it would not find application in the approach we are looking at. But there is a protein called osteopontin. Although it contains osteo in its name, it doesn't necessarily mean that it relates just to bones. And this protein has an intrinsically disordered structure, and we had a look, and we indeed found out that it can be also used to stain microcalcified lesions. However, the production of therapeutic, like the therapeutic part of my theranostic approach, was not successful with these proteins. So I stick to the method which worked best in my hands.
Thank you. The other example you mentioned is the application for atherosclerosis, dissolving microcalcification in atherosclerotic plaques. Can you tell us more about the difference between intimal versus medial calcification? Would you see other applications beyond atherosclerosis?
Highly esteemed opponent, thank you for your question. So there are for sure distinct differences between medial and intimal calcification. So intimal calcification is an almost unique feature of atherosclerosis because normally healthy endothelium is pretty resistant to calcification. And intimal calcification, for example, we often observe in a situation where we have chronic and elastic inflammation, such as, for example, in patients with diabetes mellitus. They have these problems and if it's combined with atherosclerosis, which is often the case, they also often develop intimal calcifications. Another thing is medial calcification, often also referred to as a Merkenberg disease. This is more of a feature when medial layer of a vessel, like vascular smooth muscle cells, they become calcified, and this we can also observe in CKD patients. They have the patients, especially dialysis patients, they have elevated phosphate levels in their serum. And this is something that really promotes this medial calcification, and it creates a lot of problems in cardiovascular system because it increases the overload in the heart system. So it, in the end, can lead to cardiomyopathy because the heart has to pump through the vessels which are very restricted at some point. And also another problem can happen, rather rare than often, is that the vessel becomes calcified so intensively that it just breaks, and then we can come with some really acute surgical problems that require immediate intervention. Yeah, I hope I could answer your question.
Yes, thank you. I have another question regarding aging. Can you elaborate on what happens to vessels age? About arterial stiffness and the role of calcification in arterial stiffness?
Thank you very much for your question. That's indeed an interesting one because there are different theories describing aging. So we have some models such as progeria when patients resemble the processes that happen naturally in aging, but at very early age, like people or patients who are already who are just 8 years old, they might have the features which we normally observe in patients who are 90 years old. And one of those features is indeed vascular calcification. We do not know precisely why and how these patients calcify and why vasculature tends to calcify with age. One plausible explanation would be that nowadays we just, as a population, live too long, and there was no pressure of or negative selection towards decreasing or increasing these anti-calcification properties in elderly, I would say. But yeah, definitely there are different theories on calcification and aging. One of them would be the pathology with prelaminins, like the nuclear proteins, which can also be disturbed with aging. And also there is a whole theory on free radicals and lipid peroxidation, which can also promote inflammation and result in calcification. And on the other hand, calcification is not really always a bad feature, because originally it also evolved as a protective mechanism. So it can be also considered as a protective mechanism of an organism against inflammatory processes or some pathological, like we see sometimes calcification in cancer, to delineate the pathological process. So I think in the end it's the combination of multiple factors that define the calcifications in elderly.
I go back to my first question, where we were talking about milk-fat global membrane protein. The other name is lactoferrin. The lactoferrin can be cleaved to medin, and medin accumulates with aging. Do you know if there's any link between these lactoferrin cleavage products and calcification?
Could you give a short answer?
Yeah, thank you for your question. Well, I think this was a bit out of scope of my work, but that's definitely something that further research would be interesting into. I didn't look at this particular part. Thank you.
Maybe it's the cleavage product. Thank you.
Sorry.
Thank you, Professor Meyer, for your contribution. I give the word now to Professor René Tolba. He's Professor of Experimental Animal Research at the RWTH in Aachen.
Dear Maastricht, thank you very much. Dear colleagues, dear candidates, I would like to know, because in your thesis that I read, which letter is a lot of homeostasis, the topic. And here, let's say the regulation of FETUIN-A, is there a feedback loop? So how much is enough? And because it's a potent inhibitor of atherosclerosis, why not just upregulating? Why is the body then not capable of having the homeostasis?
My highly esteemed opponent, thank you for your question. Yes, I'll start with the last part of your question. Indeed, FETUIN-A is a potent inhibitor of calcification, but in the approach which I use in my dissertation, so it's always the question about the concentrations. So the circulating FETUIN-A ranges up to 7 milligrams per deciliter, and which is a high content of a protein. And in our experiments, so in imaging and especially in the osteoclast activation experiments, we are speaking about micromolar and nanomolar ranges of protein concentrations. So at these ranges, they do not really exhibit any protectory effects, or they do not really have to do something with calcification inhibition at these concentrations. So what we actually observe in the cell cultures is just the detection or the activation of cells. Yes, that's what I can conclude from my work.
Absolutely. No, the question is more in general for the regulation of FETUIN-A, what is mostly produced in the liver, and there are several, let's say, pathophysiological conditions, let's say inflammation. Could you elucidate more the correlation also with CRP, the C-reactive protein then?
thank you for your question. Indeed, FETUIN-A, apart from its function as a potent mineralization inhibitor or calcification inhibitor, is known to be acute phase, like negative acute phase protein. So whenever we have inflammation in the body, FETUIN-A levels go down, and we do not know exactly the explanation and the background of these mechanisms, but we observe that in septic patients, in patients with COVID, we also have these we also have decrease of FETUIN-A in cerebrospinal liquid in patients who have inflamed encephalon. So that's a kind of known feature of FETUIN-A as well. But again, I do not know the background behind this mechanism.
Thank you. Do you know other regulators of the atherosclerosis, and could you rank them? So what is in your eye the most important then?
Oh, yeah, thank you very much for your question. That's more clinical, I guess. Yes, there are definitely many factors that affect atherosclerosis, and some of them are modifiable, but some of them we cannot really influence. And speaking about modifiable factors, I would say, as Framingham cohort shows, it's the smoking. So once patients quit smoking, they rapidly increase their life expectancy. For sure, another important parameter would be triglycerides, their level in serum, and the efficient control of those levels can also contribute to improvement in course of this disease. But there are also some factors that we cannot change, as like gender. Oh, I hope this answer is still acceptable nowadays. But yeah, there are factors that we cannot really change, as age, gender, and other biologically related factors. But definitely, if we address the modifiable factors, these can give us some room to treat atherosclerosis. Yeah.
Very well. In your thesis, you nicely showed that you have different binding, let's say, affinities, and you mentioned also with the comment that after the first question, the theranostics. What could be then also with your probes to be an approach, we say more in clinic, to treat then the patients? So not only visualize that, what could you foresee, how the probes could be, let's say, modified in the future also to act then?
Thank you very much for your question. So for more clinical application, yeah, the probe I showed here, they are visualized using fluorescence microscopy, and indeed it's not that easy to visualize in vivo the probes with a fluorescence microscopy. It's rather an experimental technique. However, new methods are being developed, such as intravascular tomography, which also partly relies on the same principle. But yeah, speaking about more clinically reliable and applicable probes, we can think of a radio-labeled FETUIN, which can be injected in patients as any other radio-labeled drug. And the advantage of FETUIN-A being here that it's a natural protein, so we can either humanize the protein or directly produce a human FETUIN-A that would allow us visualize features in for example, microcalcifications in patients who are asymptomatic. Or, yeah, there was rather an experimental approach with the targeted osteoclast activation, but I specifically showed the slide with atherosclerotic plaque because, in my opinion, that's the most real case scenario where we can observe these targeted therapies. And yeah, with this in mind, I put that also in my dissertation. Thank you for your question.
Thank you very much for your answer, and with the time, we're exactly at 7 minutes, and I give back to the pro-rector. Thank you.
Thank you very much, Professor Talba, for your contribution. The next member in the assessment committee is Professor Joachim Dzhanaev. He's Professor of Molecular Cardiovascular Research, also in Aachen, and I give the word to him.
Okay, first, I'd like to congratulate you on the wonderful thesis. It was really a pleasure to read your thesis in the last days, and I really enjoyed your presentation. I hope you can understand me. Yes, can you hear me?
Partly,
okay.
yes.
Okay, and you mentioned FETUIN as a component or a treatment option for vascular calcification. Are there any known mediators described in the literature, or you know, which has an effect on vascular calcification, also in the context of treatment? And can you rank these different substances in their potency and the clinical application?
My highly esteemed opponent, thank you for your question. Yes, indeed, there are means, drugs, and medications that can alter the course of calcification. And thinking of their potency, like the ones, for example, we know that they are irons, for example, pyrophosphate or magnesium. When they are added to calcifying milieu, they can significantly improve the condition, so they can kind of inhibit calcification, and that relies on the chemistry of the process, so that they can inhibit the growth of nucleation sites for ectopic calcification. There are indeed many experimental approaches. Some people try to inhibit TNAB, which is an alkaline phosphatase, which cleaves the organic phosphate and increases the phosphate in medium, and also contributes to enhanced calcification. There are drugs, for example, so-called calcium mimetics. There are approaches on calcium binding, like the clinical approach would be to use some lanthanum or polymer, which would bind calcium in the intestine and then decrease the calcium absorption, and then in patients that would lead to decreased calcium intake. However, it's all not set in stone, because now there are papers saying that it's not the amount of calcium that is important for ectopic calcification, but the product of calcium and phosphate, and that's what we cannot decrease the consumption of all ions, then we cause starvation and toxicity in patients. So even if the calcium intake is increased, these patients, like for example CKD patients, can still develop ectopic calcifications. And yes, I think those would be the method I have in mind right now. Thank you for your question.
You need the entire protein for this treatment of the patient, or do you know the active site? You mentioned of the thing that the FETUIN-A is a multifunctional protein with different functions, and which part of the FETUIN-A or which amino acids of this FETUIN is really responsible for the effect on vascular calcification?
Thank you very much for your question. Did I get it correctly? You ask which part of FETUIN-A is responsible for its action on vascular calcification. Yeah, okay, great. Thank you very much. So, as I mentioned before, FETUIN-A has several structural features that allow it to bind calcium phosphate or calcium phosphate clusters. And one of those features are extended negative charges in the domain Psi1 of FETUIN-A, and also on the C-terminal domain of this protein. And we believe that upon interaction of calcium phosphate clusters with the protein molecule, the C-terminal domain folds back and encloses the growing crystal, thus preventing it from further growth for some time. And then those calciprotein monomers, they aggregate together and form larger particles, such as calciprotein particles, and they they can also develop further. But this is the idea behind the chemistry of this process. Thank you.
And vascular calcification is one side of the coin. And the other side is bone metabolism. Do you have any ideas about the effect of FETUIN-A on the bone metabolism?
Thank you very much for your question. So indeed, FETUIN-A is one of the most abundant non-collagenous proteins in the bone. And to study the function of a protein, the best way would be to have a knockout model. So in patients, there are not many knockouts described. There is a patient who is lacking FETUIN-A, and that patient does not have any problems regarding bone mineralization. Children who are lacking FETUIN-A might develop periostitis, but then this condition is treated with non-steroidal drugs, and as far as we can follow, like as far as we can have the follow-ups, this does not cause further problems. Most probably because there are also other mechanisms that are inhibiting ectopic calcification. But we have a mouse model which is lacking FETUIN-A, and there we indeed have a lot of they have some bone phenotype, because FETUIN-A is one of the transport molecules that actually can mobilize calcium phosphate to the bone and to the osteoblasts. We observe sometimes in heterozygous mice that, for instance, or in knockout mice, that they have kind of a fracture in the epiphysis of their long bones. This is a kind of similar to a condition in children like juvenile epiphysiolysis, and we sometimes observe this in mice. This condition indicates that there's insufficient mineralization taking place in this bone. Yeah, thank you for your question.
Thank you very much, Professor Jankowski, for your contribution. The next person as an opponent for your defense is Professor Andreas Pasch. He's honorary professor of physiology and pathophysiology at the Lindenhof Hospital in Bern. May I give you the word, Professor Pasch?
Thank you, Mr. Co-Rector. Dear candidate, I would like to ask you some questions about the clinical significance of calcifications. This is a topic in the scientific field also. We have been aware of calcifications in clinical medicine since at least 150 years. Why do you think, what's your opinion, why is this now currently getting a topic to do research on it?
Highly esteemed opponent, thank you for your question. Indeed, calcification is a topic since many, many years, and Virchow was one who described a lot in the topic of calcification, mineralization, and also partly ectopic calcification. But I think nowadays it becomes a topic, an important topic again, because it also has demographical reasons. So we have aging population, people are living longer nowadays, and this longevity is also associated with ectopic calcifications that we often observe in CKD patients or in patients having some inflammatory diseases. And I think it was less of a problem when the average life expectancy is 50 or 60 years. But now when people are living 80, 90, up to 100 years, that becomes a significant clinical problem. And the important part is that it's not only the life expectancy that can be affected by such condition as an ectopic calcification, but also the quality of life. Like patients with, for example, skin calcifications, they suffer a lot from the symptoms caused by this morbidity. And yeah, hope this answers your question. Thank you.
Yes, thank you. Then let me proceed towards the question of between microcalcification and macrocalcification. Macrocalcification is what we can see already in CT scans. Why are you aiming at the microcalcification? Shouldn't we treat the macrocalcifications first? And what could be side effects of treatments for either calcification type?
Thank you very much for your question. I'd like to start with the terminology in this field, macro and micro calcifications. Indeed, if we track back papers having these terms, mentioning these terms, we would see that depending on the method which the scientist used to visualize the calcification, microcalcification can refer to something as large as 1 or 2 centimeters in diameter. And on the other hand, it's not as defined as a mature crystal already. And nowadays, we have high-resolution CT scans, and they can detect up down to 0.5 millimeter, the calcified lesions. However, even those are already quite large and defined crystals. So in my work, I was focusing on really the initial stages of the disease, the crystals which are uptaken by cells, which cause inflammation and further problems. And yeah, regarding the second half of your question about macro and micro calcifications, we believe that macro calcifications are actually, in the context of atherosclerosis, they have stabilizing effect on the disease course. So they kind of consolidate the plaque, and we think and we believe that patients with stably calcified plaques have good prognosis. On the other hand, microcalcifications, you can think of them as a cookie with chocolate droplets in it. It kind of destabilizes the structure of the whole plaque, and those plaques are really vulnerable and prone to rupture. And atherosclerotic plaque rupture is something that can easily lead to acute cardiovascular events such as myocardial infarction or stroke. Yeah, thank you.
So the proteins you have worked with, can they discriminate between the stabilizing and good macrocalcifications in plaques and the not so good microcalcifications? So if, in other words, if a patient has both problems, which will usually be the case, could that be of harm to treat it?
My highly esteemed opponent, thank you for your question. I would answer in a way that if we look at the very same picture here, we see that the standard dye, at least in red S, almost equally stains lesions of different sizes. But if we look at the staining pattern of FETUIN-A, we would notice that the most intense signal we have at the margin of these lesions, and I even termed them empty lesions somewhere in my dissertation. That's because the crystal grows from its outer part, and this is the area actually where active mineral metabolism happens, because the crystal is more or less dead inside, whatever it sounds like. But yes, we have the growing interface on the outer shell of the crystal, and we can easily detect those with the mineral binding protein FETUIN-A, which preferentially binds freshly formed matter. Yeah.
Thank you very much.
Thank you.
Thank you very much, Professor Pasch. The next person in the committee is Professor Reutelsberger. He is professor here in Maastricht in biochemistry of apoptosis. Please.
Thank you, Mr. Prorector. Dear candidate, I want to start with giving you my compliments with this nice work. I especially like your approach of theranostics that target the vascular calcification. And my compliments also go to your promotion team. In your introduction, you mentioned that there is much debate about the theory of vascular calcification. And I know there is a lot of debate going on between your promoters on this topic, and especially on the origin of the calcification in the vascular wall. And you also say that in the light of the current view, we should reconsider the theory. What, to your opinion, is now the best fit of the theory? Could you explain that a little bit?
My highly esteemed opponent, thank you for your question. Well, regarding this question, I think there is always a combination of different factors that lead to vascular calcification. So the theory which is widespread among scientists now is that almost every case of vascular calcification is associated with direct transdifferentiation of vascular smooth muscle cells towards osteoblasts. So they obtain some features typical for osteoblasts. They upregulate some markers such as tissue non-specific alkaline phosphatase. But what I can say from my experience and from my experiments is that the initial stages of calcification do not really involve any transdifferentiation. So
what do they involve then?
Yes, I think that they involve just the dysregulation of mechanisms which protect from calcification. So the lack of FETUIN-A, the lack of any other inhibitors, or the excess of calcium and phosphate, as I showed on the slide with calcifying vascular smooth muscle cells. Those images were taken 5 days after culture initiation, so there is no real transdifferentiation happening at this time point, but the cells are severely calcified. Plus the process of cell death, because cells which are facing elevated calcium and phosphate, they are in the end toxic to the cells. So the cells which undergo cell death, or I think we also observe apoptosis, that they become these pronucleation parts for further calcification process.
And is that comparable to cell debris? What is cell debris playing? Which role does cell debris play?
Thank you for your question. Well, I believe that cell debris is playing exactly this role of calcification anchor, something where the calcification starts and maybe promotes from there.
So in the cause-consequence relationship, what does your theory describe? First the cells, cellular processes, calcification, debris, or is it cellular processes, debris, calcification?
Thank you for your question. I think here we have to distinguish between the process of calcification, which is a pathological process, and mineralization, which is physiologic.
No, only vascular calcification. Okay. So, and not the Mönckeberg, but the intimal calcification. I would like to focus on that.
Well, yeah, as I said, there are different theories on this topic, but I would say that like the sequence I have in my head would be that first it causes some acute toxicity in cells. These cells undergo some process that render them dead, that turn them into cell debris, and then this cell debris accelerates rapidly the further calcification process, and when the further cells are facing a bunch of mineral, then they can undergo differentiation, and then they can follow another fate and not being vascular smooth muscle cells anymore.
So in your search for theranostics, you would think it's better to focus on the calcium crystals and not on the cellular processes?
Thank you for your question. Yes, I think that, it depends whether we are looking at the scientific question or at the clinical applicable questions.
Clinical applicable. Let's set that as a goal.
In a clinical applicable setting, I would be looking at developed microcalcifications, because this is something observable, touchable, something that we can, even with the current methods, already visualize. And cellular processes are something that is intimate and something that is not always obvious and easily detectable and visualizable in patients.
Okay. Well, you made a selection for the crystals with your fusion proteins, and important in let's assume it will be developed into a clinical agent, is knowledge about the structure-function relationship. Let's go to, I have to look, that's page 36, your figure 7. No, yeah, figure 7, it's figure 7. There you see the structure-function relationship for the FETUIN-A, that if you incorporate phosphomimetics, a certain activity of the protein is dramatically enhanced, and that's the inhibition of the precipitation. Now, if you go to panel C and D, you don't see such an effect if you fuse the FETUIN-A to the RuB3. Have you any explanation for the lack of effect of the phosphomimetics in this construct?
Thank you very much for this interesting question. Indeed, we observe sometimes that the proteins which are expressed in mammalian cell lines, that they are lacking their natural post-translational modifications. In this case, FETUIN-A has many residues which are naturally phosphorylated. Yes, that are naturally phosphorylated. And by chemical approaches, we can kind of extend this negative charge, kind of mimic this negative charge of phosphorylated residues. And in some cases, if we have dysfunctional protein, we can rescue the functionality of such protein. But indeed, there were some fusion constructs that initially had normal calcium phosphate binding capacity. And actually, it was out of curiosity to exchange the residues there and see whether these would further enhance their calcium phosphate binding capacity. But yes, that was the case with FETUIN-A emerald, for example. That was dysfunctional, and then we rescued the phenotype, as in the figure 7E and F. But yes,
with the ruby, not with the ruby. If ruby is attached, it looks like the FETUIN has full activity without being phosphorylated or without the phosphomimetics. Yeah, so it can be three-dimensional through three-dimensional structural changes, but you don't know, you haven't investigated that.
That was indeed a big discussion point, because the FETUIN, like emerald and M-ruby, look really alike, but one of them causes these problems with FETUIN-A and another one is totally functional, so we didn't have a good explanation for these phenomena, so we just took it because it functions.
Yeah. Whatever, it inhibits the precipitation of calcium phosphates or something else, I don't know, but probably phosphates. Then you use this fusion protein in an experiment. And then we go to page 44, and that's figure 14, to measure progressively in time the precipitation of calcium induced by vascular smooth muscle cells. And there you see an increase of the uptake of your label. Wouldn't you expect to see nothing, because it inhibits the precipitation of calcium phosphates?
Thank you very much for your question. So here it's all about the details, because it inhibits calcification.
It always is.
It inhibits calcification at physiological concentrations, but here the amount of FETUIN we added, I believe it was as low as 6 micromolar, which does not really affect the calcification dynamics. And on top of that, the cells were cultured in medium with depleted FCS count.
I have to correct you. When you go back to 6 micromolar gives full inhibition. Sorry? Or I don't see it. Panel C and panel D. Can you see it?
The concentration was 0.24 micromolar in the image.
Okay. So, and then I have another point of concern in this case. It is known that these cells under calcifying conditions, they pinocytose a lot. So they take up components from the extracellular environment and incorporate that into vesicles. How sure are you that the dots we see here are calcium crystals?
Thank you very much for your question. Indeed, there is an easy proof of concept experiment for this question, and I also stained the fixed cells that cannot perform any activities such as pinocytosis, so I'm pretty positive about this finding.
Okay.
Robert Dzhanaev, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
Thank you.
Please, all right. the microphone on.
We open the session again. Robert Dzhanaev. I hope I speak your name well. The degree committee here present has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account your previous qualifications, the degree committee has decided to grant you the degree of a doctor. Professor Schurgers is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
So before saying the magic words, I have to ask you something. Do you promise to work in accordance with the principles of scientific integrity at all times? To be careful and honest, transparent, independent and responsible?
I promise.
Then I can say the magic words. By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Robert Dzhanaev, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of our university. That was the official part, Robert. Dear Dr. Dzhanaev, dear Robert, I'm the first one that is able here to congratulate you from this place with this fantastic achievement. And in these congratulations, I also want to congratulate your supervisor from Aachen, Professor Willy Jan and Deschamps. I also want to extend my congratulations to your family, hopefully present online, your colleagues and your friends. I also want to thank the members of the thesis assessment committee present here in person, but also the ones that are present online for their involvement and participation. Thank you all. A special thanks to the assessment members also from Aachen, as this PhD is part of a double PhD degree between Aachen and Maastricht. Dear Robert, you are ESR number 12, and you're also number 12 of the 15 ESRs, early stage researchers, obtaining a double PhD here in our European Horizon 2020 ITN IntriCare. This collaboration between 3 institutes, Maastricht, Aachen and Stockholm, was initiated quite a long time ago in 2017, and you were one of the first that started in our consortium. The basis for IntriCare was laid already well before this 2016 start date, and was based on our great collaboration, Willy, between Mr. FETUIN and Mr. MGP. Within IntriCare, our aim was to investigate the role of microcalcification in the involvement of vascular remodeling leading to atherosclerosis or vascular stiffening. In this setting of friends, 15 ESRs were selected. And I already named them many times: Germany, England, Greece, Poland, Romania, the Netherlands, Brazil, Pakistan, China, India, and last but not least, Russia. A wonderful group of young, talented researchers. So Robert started working on the project number 12, innovative platforms to generate FETUIN-A-based imaging agents for diagnosis and treatment of microcalcification. And I think you succeeded in that. You showed us today that you already made a first attempt to go into a preclinical, maybe clinical stage. You did the secondment also in our group here in Maastricht, and a very fruitful collaboration resulted in many joint publications, which I very cherish. The fact that you continue now as a postdoc in Aachen for another 2.5 years says enough about your qualities. And with that, I give the word to my dear colleague, Professor Willy Janen Deschênes.
Dr. Dzhanaev, MD, PhD, and doctoral. Robert, let me congratulate you on your fantastic achievement of today, of getting a triple degree even, that you worked so hard for. First, an MD that you had to receive to be able to participate in the Co-Tutel program between Aachen and Maastricht, which was ingrained in IntriCare program, just like Leon just mentioned before. So now you finally received the much longed for PhD, and at the same time you're granted the doctoral medic from Aachen University. When we started, we did not know what we were in for, but you had the stamina to navigate, a little help maybe from some people around, the stupendous regulations of the various academic bodies involved in this project. I freely confess, you were not the only one doubting the rules sometimes that surround this lengthy process to receive the highest academic degree that faculties around the world can award, and that is the PhD degree still. In hindsight, however, we come to understand that some of the hurdles are mindfully installed and are jealously watched over by the faculty bodies. The rules prevent first the too faint-hearted who give up early from getting the degree, as well as people who try to buy in with cash and want to reach the goal cheap. Having mastered all the tests with bravado should make you proud, and it does rightfully so. With this comes the obligation to live by the academic code or good scientific practice that you just agreed to follow. In these times of boundless international competition and the increasing use of AI to speed up things, it will be ever more tempting for you and your comrades to bend the rules and rush to publication. So here's my advice. Don't rush things. Think twice and let the finished work sit for a while. If you still think it's worth publishing, go ahead. Now, the current publishing becomes ever more in shambles, and we don't know where it is going. But here's some advice, maybe, that the exploitable parts of your research should be protected as early as possible. We did that. We wrote the patent applications were due. Then we should deposit the work on the pre-publication server, and then we should share freely with our colleagues and allow them to participate and maybe even add their bit to co-publish, and then we go into the formal publishing process. I guess you've noticed by now that this is pretty close to how we handle publication in the group. And now you know why. Let your friends, collaborators, and peers know as soon as possible what you're up to and allow them to contribute. That is important. Why am I telling you all this? Very simple. Because from our first telephone interview, when I asked this young aspiring medical master from Vladikaukas why he would prefer entering a lengthy process of receiving a PhD abroad instead of just following the steps of his parents, maybe even grandparents who were doctors themselves, he said, because I want to do research. And I asked you again, and you had the same answer. So you've repeated this several times over the years. So it's safe to say Robert is the curious type. I hope you're even more curious and interested in basic research now that you have left your first mark. I know, and I would like to remind everybody that Robert is also a pretty good clinician, and he stepped in during various occasions, and he graciously and gratuitously counseled all the poor souls that he stumbled across in his living places, as well as during sports events. Once during a sports event at RWTH Aachen, two of our colleagues, one is actually present, knocked each other out. And Robert stepped in like the good doctor in Netflix and, soothed the souls and calmed them down until the paramedics arrived. They had to be taken to hospital. Also, you prefer to be an all-round nice guy, and you certainly prefer excitement over routine. You're a good example to your colleagues, and especially to the younger ones, that you guide, although you certainly also know how to throw a tantrum when you feel hurt. I had the privilege of being your boss for 6 years now, and I have to tell you that I don't want to miss a single day of it. You know, although maybe we had our rows. It gives me great pleasure to see how you've grown with your tasks, and I'm sure you will continue your successful path in medicine and in academia. You have applied for board certification to return from bench to bedside, and I hope that you will achieve this goal as soon as possible. Please don't forget the original motivation. I want to do science. Because in my experience, the few medical doctors who have a genuine interest in science are among the best in our field. Because they know both. They know the whys and hows of the method, and they know the why and for who they do all the work. And I hope this becomes second nature. Let me congratulate you again for today's and past achievements. I would also like to congratulate your family and thank your parents, who I hope are online, for sending over this fine young man with impeccable taste and manners. Robert's clothing style is legend. You know, like today, spotless, apart maybe from this one smelly carnival suit when you dressed as a plague doctor. But that wasn't your fault. Too bad your parents could not be here in person, but at least we can congratulate them online. And if so, in lieu, your cousin, and this is now for me the hardest part of the whole thing, Pozdravляю, спасибо. As I said before, Robert is the curious type. They say curiosity killed the cat, and everybody knows the meaning of that proverb. I think in science it's the other way around. Lack of curiosity kills science. So I do hope that you stay curious and maintain your curiosity. You have a lot of it. And I hope it will never harm you, Robert. All the best, and keep doing what you did so far to arrive at the point where we are today. Congratulations again. And with that, I give back to the pro-rector.
Thank you very much, Professor Dzhanaev. Also, Professor Schurers, both, thank you very much for the touching laudatio. And you, Dr. Dzhanaev, on behalf of the Maastricht University, I also congratulate you for the degree that you have acquired. It was a wonderful event, and it is a very pity that your parents and family and friends from Russia couldn't come over, but they are online. And greet them on behalf of the university and tell them that you did a really good job here and that they should be very proud of you. With that, I close the session, and after the formal closing, we have a few photo sessions, so I close here the session. YouTube goes off now, I think. And yeah, so we have online the people. We have on the screen, we have the committee members, and we can stand in front, and then we can make a few pictures. Yeah, and after that, we give the